So, here we go. If you take percutaneous ablations in general, you can kind of divide them up on how they work. One is poisoning the tumor, one is basically freezing or heating it, and the other is electrocuting it, IRE. So if you take those three big categories, chemical is one we don't think of much anymore, but now that Obamacare is coming, considering how cheap this is to inject alcohol through a needle, maybe actually we ought to throw away these and just worry about injecting alcohol. That's what they do in Asia. I think a lot in Japan, places they're kind of going back to alcohol injection. Another one, thermal ablation, which is, of course, cryo, which is freezing it. Hyperthermics are RFA, microwave, and laser and things we don't use much. Then we've got IRE. So big difference is IRE is the only one that electrocutes, basically. It creates pores, and we'll get into how that works in a second. So RFA, I think everybody knows about RFA. It's by far the most common. It's kind of the gold standard. It's what everybody's familiar with. It basically creates an electric current between a probe and a grounding pad, which is stuck to the leg usually. And it excites ions around the probe, and then that presentation's not working perfectly, but excites atoms and causes movement of molecules surrounding the probe, and then heat is generated. So it's basically pretty simple. It relies importantly on an electrical current between the grounding pads, which used to be shown down here, and the probe, which is here. So if you don't have a circuit, you're not going to heat up the tissue. I'll tell you how that matters in a few minutes. There's a few kinds of RFA. One is, let's see, let me turn this up. One is this type, which is a single probe with these little tines that come out. This is, they call it a RITA. RITA used to be a company that created it. Now I think Angiogenomics owns it, and they still call it a RITA. And the other is using multiple probes at the same time, and then the heat develops around each individual one and kind of adds together. RFA in general takes probes that are sort of middle of the road size. They're not huge, they're not small, they're just kind of medium size. The amount of time that it takes is generally around 15 minutes. And the size that we're dealing with, about 3 centimeters is one probe, and if you use multiple, you can get up to 5 or so. And of course, you can reposition these probes and get a bigger burn area yet. So depending how much time you have and how much you want to do, you can always ablate more. But generally, one probe does 3 centimeters easily. Okay, next one. RFA, of course, you have to follow up and diagnose and see what they look like later. And RFA is pretty straightforward. Here's an example of a CT before and after RFA and an MRI before and after RFA. And RFA is pretty straightforward because it creates heating, it causes inflammation, and centrally it causes cell death. So generally on CT scans, you get what you think. You get central necrosis, peripheral hyperemia, gradually decreasing over time, and time being like a few months sometimes it takes to decrease. At this point, there's not a whole lot of inflammation, so this one's probably a couple, actually this one's just a few minutes, but inflammation will increase. In a few days, there'll be lots of inflammation around here. You might have to wait 3 months until it gets easy to read the scan later, because for a while it's going to look worse. It's going to look really inflamed. For that reason, I'm not going to get into it today too much, but I think MRI really is much better in following up your ablation, because MRI gives you a lot more information. And for that reason, we're doing MRIs on the day of, and then we do 1 month and 3 months and 6 months, and we're gradually learning actually the differences. But in general, RFA is pretty simple. You heat up the tissue, it burns, and it's inflamed at the margins for a while. Complications from RFA, there's a lot listed here. I don't even expect you to read all these. Most of them are obvious. You know, you can cause a hemothorax or pneumothorax. I've given pneumothoraces a couple times. If you're going intercostal, like you have to most of the time, you're going to create a pneumothorax eventually. Most of these are really not much of a problem. I suppose they can happen and you have to think of it in your mind. Really anything is possible. But in general, according to studies, the complications of major complications are pretty small, really. 0.9, 2.2%. You compare that to surgery or wedge resection of the liver, this is pretty desirable. But what does happen are the ones that I've highlighted here. Acute pain, RFA tends to hurt more than IRE for sure. Similar, maybe not as bad as microwave. Skin burns, they do occur. I had one very bad skin burn, and what happened was it occurred at the grounding pad. When they stick that grounding pad and complete the circuit, if you take the grounding pad back off and you re-stick it, it doesn't function correctly, which we learned after one case. If you take a grounding pad off, you got to throw it away, put a new one on. So that's a real possibility. Transient liver decompensation, this can happen if you're treating really advanced stage cirrhotics, child C type cirrhotics. You have to be careful how much tissue you ablate. The dangerous one being microwave, because microwave you can really get a big ablation, and you might actually cause decompensation. These two in blue here, these always happen. Tumor lysis syndrome will always happen. If you don't notice it, it's probably because you're not looking or not asking carefully. Pretty much everybody has it. It's usually it's within a few days and then ending by a week. And there's some differences. RFA, they kind of get the tumor lysis fairly quickly. IRE, it's a little delayed onset. That's kind of anecdotal in my impression, but we'll get into it more. RFA generally, along with microwaves, give you quite a bit of tumor lysis. IRE, you get a little less. IRE hurts a little less too. So post-ablation syndrome, like what is it? I would say it's at least a third of patients. In my opinion, really everybody, if you ask carefully enough. It's flu-like symptoms. It's a fever, delayed pain, malaise, myalgia, nausea, vomiting. Not so much the nausea, vomiting, luckily, but they all get a fever. They all get malaise, and most of them will tell you that bones hurt. Seems to be very common with IRE, especially. I don't know. I keep hearing the word "my bones hurt," so I don't know if there's anything to that, but everybody has something. They are self-limiting. We're talking Tylenol, ibuprofen kind of territory, so not a real big deal. Not like the post-ablation syndrome from big chemoembolic and that sort of thing. So microwave. Microwave is the second in thermal techniques that we're going to talk about, and microwave is powerful. That's what you really have to know about microwave. If you want to sound intelligent, you won't talk about a probe. You'll talk about an antenna, because technically the microwave is an antenna. It doesn't use grounding pads in the way that RFA does. It's kind of its own device. This is what the insides of a microwave needle or antenna, sorry, I don't know what I'm talking about currently. The antenna of a microwave looks like this. It emits the microwaves out in all directions, and what you need to know is it's powerful. It will ablate regardless of what tissue you put it in, whether it's electrically conductive or not, and it will definitely do harm if you're not careful. So since it's a thermal technique, microwave does cause motion of molecules, which then induces heat, a lot like RFA, but much less tissue sensitive, and of course there it's dangerous. Here's what some of the heating patterns look like around a microwave antenna. Generally, the microwave antennas are larger than RFA and larger than IRE, but smaller than cryo. So they're a little big. They're slightly disconcerting, but still not the largest. Cryos are pretty huge. Microwave causes big ablations. So, you can go up to 7 centimeters sometimes, and you can just take one probe and keep repositioning it and practically ablate half of the liver if you're not careful. And it's not always apparent the zone of differentiation between, heated up terminal liver cells versus normal. So sometimes it's bigger than you realize. It can be pretty quick. I would pay attention to this number, the 5 minutes. Microwave, you turn it on, it ablates quickly, and you have the opportunity to reposition and do more. So it's fast. You can guide it in any method you choose, and that's fine. I've never used multiple probes at the same time with microwave, but if one were to do that, you can see how they interact with each other. That's kind of interesting, but not real common. Here's what microwave looks like on CT and MR. It's very much like RFA, but the margins are a little less distinct. When you're doing these, if you're laying on a CAT scanner and you put the patient in and look at the liver a few times during the ablation, it's not always very apparent where the margins of the ablation zone are. And this is a case where we gave contrast. With RFA, you'd have quite a bit more differentiation between normal and abnormal. So microwave can be kind of sneaky. It'll create a bigger defect than you realize. And, a defect this size is pretty hard to create with anything other than microwave. So complications, the literature says something similar to RFA, but I would say that there's probably more complications with microwave because you can really do quite a bit more injury. It definitely damages collagen, so you get bile duct injuries are possible. The one thing that is always in my mind is that it will cause microwave will cause thrombosis of portal vessels, as in the portal vein. It'll even thrombose the main portal vein if it's a slowly flowing portal vein, like an advanced cirrhotic, so you can really do some harm. It'll clot hepatic veins, which actually is not so bad, but hopefully not all three. Fever, this is really kind of generic. Fever and pain, all the tumor lysis syndrome things are what you're worried about with microwave, but anything that you get it close to, it will burn. So regardless of the tissue composition, if you get it next to the gallbladder, you'll burn it. If you get it next to the diaphragm, you'll burn it. So microwave is kind of indiscriminate, but useful. So let's talk about cryo. It's still a thermal type of ablation, right? It's just that it's cold, and it works like a refrigerator. Basically, if you take a compressed gas and you release it suddenly, and it forms compressed gas, and it's a liquid, and you release it, it forms a gas, and when it does, it absorbs a lot of heat and it becomes very cold. So you can imagine that it would create an ice ball. And since you have a couple lumens and a few directions of flow, I believe that's why the probes are fairly large. So this is what a diagram of a cryo looks like here. And here's one intra-op. I'm not going to get into it too much, but when I think of cryo, I think of renal. Because urologists are probably the ones that use this more than anybody else. They're big probes, so percutaneous is a little harder. They like to do it laparoscopic. It's great for the kidney because the ureter is sensitive to heat and it's just generally sensitive to anything you do. So you can cause ureteral stenosis. So cryo is nice because it has a very little effect on collagen, a lot like IRE, and it spares the collagen. It generally spares the ureter. So if you're going to be doing renals, I would think about cryo, be careful with microwave, and RFA is pretty standard. Everybody uses it everywhere. Future directions, I'd say cryo is a real candidate for breast in the future because it doesn't cause scar and it doesn't damage collagen as much. So breast for cosmetic reasons may be the future. So let's get into the good stuff, is IRE. IRE is pretty new. There's been reversible electroporation around for a while, and the idea of electrocuting tissues is not new at all, but the advent of a marketable device you can buy and the rep will deliver to you to put in a patient, that's pretty new, like 6 months or so. It stands for Irreversible Electroporation, and the idea is that it's not causing heat. It's electrocuting the tissue between two probes, so a positive and a negative, and it creates pores in the cells so that they're no longer able to survive. It passes a current between two probes. It doesn't cause heating, and it tends to spare structures. So that's a quick rundown. We'll get into more about that exactly. But in general, it's an interaction between two probes. So the more probes you put in, the more interactions you're going to get. If you worry about magnetic field lines, it looks like a donut. Of course, IRE causing pores in a cell, as you can remember from all of your biology, if a cell can't maintain its gradients, then it dies, and that's exactly what we're causing here. What you can also imagine is if you take the center of where two probes are located, of course you're going to get this central area of complete and irreversible definite cell death. And then you're going to get a gradient from, total death to unaffected liver, and that's where the interesting imaging comes in, because there'll be a point where there's a liver which is reversible, as in it's still going to live, but it looks different on MRI. So there's a point where there's no enhancement in the center, then there's a hyperemic margin where it's probably irreversible, and then there's a zone where it changes from affected and enhancing to totally unaffected. So I'll show you some more, but there's a lot more going on, as you can see. Okay, that's fine. So I guess I was describing what we're talking about here. In the middle, in the most extreme, if you over-ablate with IRE, you'll actually cause heat, but that's not our goal. Our goal is to be right in the sweet spot, right in the middle, where we're causing cell death, we're not heating much at all, and it's irreversible. So what's next? The problem with IRE is that it's fairly painful to do technically. You can't, there is a single probe device, but it's just really, I won't even talk about it because it's not necessarily always available. Basically, it always requires two probes because you have to have a positive and a negative, right? You have to pass current from one to the other. So you're lucky if you've got a lesion so small you can do it with two probes. It never happens. You're always dealing with 3 or more probes. We generally use 5 is really typical. We'll put 3 in the middle, 2 on one side. We'll move those 2 to the other side and reuse them because they're expensive. But anyway, some unique things about IRE and also problems. We absolutely must have general anesthesia for IRE, which is not the case for anything else we've talked about. You can do the general for any of the others if you choose, but it's not required. But for this it is, because you're electrocuting to such an extent that they'll literally jump off the table without trying to when you pass this much current through the patient. So have to have general anesthesia. That's the problem because it kicks out some of our best patients. Some of our best patients in IR are the sickest who can't get anesthesia. Another one is it has to be synchronized with the EKG. IRE gives electric current, and it gives actually a lot. It gives 3,000 volts and 50 amps. So if you know anything about electricity, that's like enough to run like a couple MRI scanners. The trick is that it gives them only during a tiny and short period of the EKG cycle. So it gives a lot of energy, but during an extremely short time. And in order to do that, it has to synchronize perfectly with the heart rate. Another limitation is that IRE doesn't create very large burn zones. Really, about 3 by 3 is what you need to know. Bigger than 3 by 3, you have to reposition all the probes. And time-wise, it's right in the middle. It's not particularly heinous. It's not especially fast, not really slow, right in the middle. So let's compare the two competitors. We've got RFA, which is everybody's used to, and that's showing up right now here on the left. And the idea is you put the probes or a single probe right in the middle, and it heats up around them. So you get something like that. And they overlap, and your burn zone is, of course, the area where the heat overlaps. IRE is a completely different animal, and it's very unique, and it took me a while, really, to get used to this idea. You bracket the lesion. And what that looks like is there's really very little heating outside, there's very little cell death outside of the probes. It's really mostly around where you put the probes and in the center. So with all these others, you get a lot of heating outside of the probe, but with IRE, you get very little outside the probe. Mostly it's cell death between the probes. So you have to put the probes around the outer margin of the tumor, not in the middle. If you put the probes in the middle, you'll just get a little burn right in the middle of the tumor, so that's no good. So that's a major difference, and it's the source of really the number one problem with this technology in my mind is it technically is difficult to position probes perfectly around a tumor in the constraints that you have to meet, which are, I'll tell you just so you know, they need to be parallel, so not convergent or divergent. They need to be between 1.5 and 2 centimeters apart. So, I mean, we're talking a difference of like millimeters. In a liver, where you have to place these things maybe up at the dome, frequently between the ribs, so that you can't just put the probes anywhere you want. So they got to be parallel and within a particular number of millimeters apart. So that's technically it's kind of hard. This is what the machine looks like while you're doing the ablation. Really, this is what it looks like after. This is a summary of what we've done. So up here we can see each individual spike is one passage of current. It's one current event between two probes, like between probe 1, 2, and then 2, 3, and 3, 4, and then back to 1, 2. So here's all the events. Here's how much each of those developed or gave in terms of amperage. And this one's a pretty low one. It's 20 amps, so most of these are 20 amps. That's a little low. We much prefer somewhere around 40 or 50 amps, but that's fine. This is an idea of what it looks like. By the way, each of these, of course, is one pulse given at a certain part of the cardiac cycle. So each one of these is one heartbeat. And so you can tell, if you counted them out and averaged the heart rate, that's how you get to the 10 minutes. So if they have a really slow heart rate, you're going to be standing there for a long time. If their heart rate's really fast, like more than about 115 beats a minute or so, it may be too short for the machine to capture it, and it may not work. So I have to give them beta blockers. So IRE, I believe, has some pretty unique imaging features that are still being worked out by a number of people, including myself, and we're trying to figure out, I call it the penumbra zone, because it really reminds me of a stroke. You've got central cell death, and then you've got this reversible margin at the edge, kind of like the penumbra. It's abnormal on imaging, like in the brain, but it's still going to survive. And I think that allows you to know on an MRI, on the day of the procedure, what area is going to be destroyed and what area is going to remain, so you have prognostic information immediately. That's unlike microwave and most everything else, RFA, which takes time, sometimes 2 or 3 months before you know what you've done. So benefit IRE. Here's some examples of IRE. So I told you IRE is great because it doesn't damage surrounding structures, and here's the case. Here's the IVC, of course. Here's the hepatic, middle hepatic, left hepatic vein. Here's a tumor right in the middle of, right between all these important structures, and I didn't really even worry a bit because IRE, it only destroys the areas that you bracket. So I put the probes out around the margin, and as long as I didn't put the probes inside the vein, it's not going to thrombose it. If you microwave this spot, and you probably take out one of these hepatics. If you microwaved it and you left it on a little too long, you might actually cause real thrombus in the IVC. So you can really do harm. RFA, you can thrombose vessels with RFA as well, but not quite as easily, but certainly possible. Here's another example. This patient here down at the bottom. This person had a wedge resection. This is the cut surface of the liver. Here's a little recurrence at the margin. This one might have even been peritoneal. In any case, it was right next to the colon, right? So that's kind of worrisome. How are you going to kill the tumor and not hurt the colon? IRE is great for that because I put the probes at the margin. I actually put one probe was, I'm not showing it, but was, I think, touching the colon, and the other one on the other side, and the current just went back and forth between those two, and it spared the colon. Here's what it looks like post. And not even any colonic thickening, which is kind of amazing. So IRE safety, really I'm talking safety to the patient and for your own mental health. It's a pretty stress-free procedure. It's difficult to place the probes, but if you get them in correctly, you're not going to hurt anything, which is nice. This report said no post-ablation syndrome. I would agree. The post-ablation syndrome, pain, fever, all that is smaller with IRE, but it's not negligent. It's there. It's just that it doesn't ablate as large of an area. There's not as much tumor and dead tissue lying around to make you sick. So it's there, but overall IRE definitely easy to tolerate. So far, metal stents, prostheses, probably safe. How about pacers? So IRE, obviously cardiac gated. Reps tell me it actually is possible to do for a paced patient, but that you would be advisable to have the pacer rep present to help adjust or restart the pacer. I haven't done it, and I wouldn't worry about it at this point. If I had one, I'd probably just do RFA or something else. IRE complications in general smaller, and there's a lot of question marks. It's pretty new. People don't have really good numbers yet. All the things that you worry about with others, like thrombosing a vessel or damaging adjacent structures, are really much less likely. One real possibility, I haven't seen it though, is arrhythmias. The device makers tell me that in pigs they did induce a few arrhythmias, and I think in people there's been one induction of atrial fib. Not surprising when we're talking about IRE. It's a large current, it's a lot of electricity, and it's gated to the heart. So if it's gating incorrectly and not giving it during a rest cycle, then you could imagine you could do some harm. But so far, it hasn't been a problem. More theoretical. I'm going to skip with this. Tissue characteristics of the tissue you're ablating. So in general, this is kind of a big deal, really, because when you're deciding what do I want to use, I've got RFA or microwave, IRE, whatever you want, which are you going to choose? Generally, you think about what you're ablating and where it is. Tissue perfusion and the heat sink effect you may have heard of. If you ablate a tumor which is touching a big vein, the vein is going to suck heat away from your burn zone and might allow some tumor to live at the margins. So RFA is pretty susceptible to heat sink, and that's a negative because you leave a live cell. Microwave doesn't really care. It ablates through everything, so not much heat sink effect, but there's a good chance it'll take out the vein if it's close to it. Thermal conductivity is, we're mostly ablating liver, so it doesn't matter. The liver is pretty homogeneously thermally conductive, so you get pretty spherical defects. Electrical conductivity is a big deal if you leave the liver. Take the lung. You can imagine the lung is not very electrically conductive, so if you've ever tried to do an RFA of the lung, it can be a problem. Sometimes you have to inject a little saline around the tumor in order to get it to conduct electricity. So what can you do about that? Well, you could do IRE if you're an adventurous. I don't doubt it would work, but it's a lot of probes in the lung. Or you could just do microwave, which is what I've done. Microwave doesn't care about conduct. It doesn't care about anything. It just ablates from the antenna out. So here's just a few pictures, really. Some of this is kind of conjecture, but there's some truth in here. Here's the RFA. You get fairly impressive edema after your ablation. Sometimes you even cause some interaction between the probes along the shaft as they're going in. Microwave, the important thing is it can be kind of a cult. Sometimes you don't see much. I mean, this is even a contrast CT. It looks like a pretty good arterial phase, and look how little you're actually seeing as far as what's dead and what's alive. So slightly disturbing. And then IRE, I'm a little partial to IRE because I think that it works and it's kind of interesting. It generally is very distinct. The zones of cell death and hyperemia and such, they're pretty distinct and easy to see. And of course, it's a little unfair because I'm showing you an MRI. MRI shows you everything, but you get similar effects. If you look at a post-CT RE and post-RFA, they look kind of similar. But okay, so how about in general pros and cons? Kind of a repeat, but I don't think it hurts. Percutaneous RFA, it's more mature. It's been around for a long time. It's the gold standard. Nobody will fault you for using it. You can use it anywhere if you have experience. And if it's the default and you're starting to practice somewhere, bringing the hospital a new technology, just start with RFA. The cons are that it's susceptible to heat sink. It's going to suck away, big vessels are going to suck away heat and leave residual tumor. Everything is limited in location. In the past, the size of the zone, the defect that you can create with RFA was limited by charring. And that was kind of before all the cooled devices. Nowadays, most, if not all, the devices circulate water in the RFA probe and keep it from getting too hot. Because once it gets too hot, it basically electrically insulates itself from the liver and your burn zone is reduced. Microwave, you can do it anywhere, including lung. I think the important thing to remember is it's powerful. If you need a big defect and you are not worried about ablating a close by important structure like gallbladder, colon, stomach, vein, then microwave is your thing. And if you're interested in new things, IRE, when I think of IRE, I definitely think of cases which are difficult, as in lots of post-surgery cases where there's lots of other structures stuck to or close to the liver or the tumor, what you wouldn't usually expect, like half of the liver is gone and the stomach is lying on the tumor, or the colon is stuck to the cut margin, or you've got tumors right up next to the hepatic veins, or right down in the hilus of the liver. Like if you have a tumor in the hilus of the liver, all of these are definitely an issue. That's a little bit scary, but I've ablated with IRE tumors like dead center in the hilus of the liver, and they've done well. It doesn't take out the vessels, doesn't seem to damage the bile ducts. But 100% of the issue with IRE is the difficulty of placing those probes. It's difficult to get them appropriately positioned, and they don't burn a huge area. So about 3 centimeters is about your limit. Okay, so the next one, I would say operator dependence. We're going to talk more and more about studies here, and I think IR in general is going to become more of an evidence-based medical practice, and all these things depend so much on operator dependence. If you're skilled and you place the probes correctly, turning on the machine is going to be the easy part. It's 100% about knowing what to ablate and where, so it's very hard to design head-to-head comparisons of these things because it's so operator dependent. And of course, you're completely reliant on imaging. So if you've got a fairly massive person and you're trying to do an IRE and place 5 probes a couple millimeters apart parallel and 15 centimeters deep, good luck. So maybe use RFA or microwave. And the cost, I'm afraid this is going to keep coming up more and more. Of course, what would you guess is more expensive? It's IRE. Probes are around $2,000 to $2,700 each. So if you're using 5 probes and patients on Medi-Cal, Medicare, Medicaid, can be an issue. This has caused me problems. We have here at University of Arizona, we've got a handful of patients with insurance and a handful with not, and they tend to balance each other out, but nobody's getting rich, that's for sure. Combination treatments, of course, need more science, and we're talking combination with other specialties like oncologists, and it's a pretty difficult thing to organize combination comparisons, head-to-head trials between different specialties. So this is going to be a hard, tough area. Okay, so who are the types of patients and what do you use these devices for? Generally, you're looking for people who can't have something else, as in they've tried chemo and hasn't worked, or they're growing despite chemo, people who are not surgical candidates, people who have problems on both sides of the liver, so it's not possible to surgically remove half the liver because you got a tumor on both sides, or a tumor at the margin between left and right. So these are really our patients, ones with METs, ones who can't have surgery, ones who have had surgery and failed. And if you'll notice, I gave one exception to this rule. IRE unfortunately requires general anesthesia. So usually, we pick the worst and sickest of patients, but IRE is a little selective. It's got to have general anesthesia. Contraindications, you got to always remember you're supposed to be doing the patient some good. So if they have disease everywhere, besides just the liver, you don't have dominant liver disease, you're wasting your patients and your time treating them. So you really need to have liver dominant or disease that's treatable, not with brain mets, and you're worrying about the liver. That's kind of crazy. Other ones, of course, these are intuitive. Child class C cirrhotics are pretty sick, and they can't handle losing even a little liver tissue sometimes. So the others, active infection, of course, is always an issue. Sometimes you don't realize it, but they can all cause abscesses. So if you're ablating and they have a known active infection, you should be careful. Big tumors, the size, I wouldn't memorize the size too much. 3 and below is a great size. 5 and above is starting to get kind of tough, just general numbers. Post-procedure care, these percutaneous techniques, people don't get too sick. I've been sending and usually send everybody home. I haven't sent the IREs home. I've kept them overnight, and that's mainly because it's so new and we're kind of learning. For most of those, we've just kept them with a day and then let them go home, and they've done fine. Most of these people don't have much pain. If you ablate something in the center of the liver, it doesn't hurt much. If you ablate something at the serosal margin, it hurts. If you ablate something along the diaphragm, it definitely hurts. So, you can predict which ones are going to be painful. I won't get into this, but I would highly recommend when you start practicing yourself, assuming you guys are all fellows, you got to have your own clinic. If you don't have a clinic, there's so many reasons why that model of IR is not going to work in the future. You have to have a clinic to get the patients to decide what they need, percutaneous or transarterial. You have to be able to follow them up. You have to be able to know when to reschedule them because you've missed some tumor. It's just essential. If you don't have a clinic, I don't want to say you don't have any business doing this, but you better have a really tight, well-established collaborative relationship with your oncologist or referring, so basically you're making them do all of your work. This is also your opportunity to establish the labs and the imaging, because you don't want to just ablate something and walk away. You need to ablate it, make sure that all of their imaging and everything to follow up is set up, because if they just disappear and think that you treated them, and they have a recurrence, it's kind of your fault, so you got to be careful. This is kind of my gestalt of around here. I tend to have pretty difficult patients, and realistically, I retreat a fair number. At least 20% seems a lot to me, but that's typically the case. If I just did microwave, I wouldn't retreat many at all because you get it all. But with IRE especially, I would say the retreating rate is higher. So I'll talk a little bit about staging and selecting your patient, basically, so that you will have heard of these things. Because when you're sitting at a conference and you don't know what child's class your patient is, or you don't know what they're talking about, that would be embarrassing. So you should check these out if you don't already know them. You probably do. So everybody says child's class ABC. C is, they're very sick. These are the really shrunken, nasty, hard-looking livers, 100% hepatitis, patients sick, and they're going to die pretty quickly if you do nothing. Child A are the walking, talking, basically normal people. You may not even realize have cirrhosis. Maybe they don't even know. There's another staging outcome-based system, the Barcelona, the BCLC. Everybody just says Barcelona. This seems to be showing up more and more in the literature. Everybody's really liking the Barcelona, especially for yttrium 90. A lot of the studies classify the patients of the Barcelona staging. So I'll give it to you here. Hopefully this is available for you to look at later, or you can look it up. But basically you have every range from the very healthy to the very unhealthy, and of course this correlates with child's ABCs as well. So which patients would you like to get? Obviously, you want for your procedures, you'd love to have these, but what do you actually get offered? Usually you get offered a lot of these and some of these. So be aware that when you're doing sick patients, your outcomes can be worse. You got to be careful. So here's a proposed Barcelona-based staging and treatment schedule. I found following these kind of charts is nearly impossible. It's good to look at them so you have a general feeling of what you ought to be offering people, but to actually expect oncologists and IR docs to follow a chart like this and surgeons, of course, is nearly impossible. Other things trump this in a huge way, like patient refuses any more chemo because they got sick last time and they don't want any more. Or patient can't have surgery because they have a new cardiac event. Big clinical problems come along and just destroy these things completely. So generally, having an idea of the general progression is useful to know. So here's just a few examples. There's been a lot of papers comparing RFA, especially being the gold standard, versus other things like surgery, and it's starting to get to the point where some people are actually thinking about sending us ablations on solitary single liver lesions instead of actually going to surgery, and that's kind of a crazy idea, but not to IR docs, because for us it's a lot easier in our perception for a patient to recover from an ablation than surgery, but so that's evolving. I think I'll cut through these, but generally size becomes pretty important in the decision tree. The bigger it is, it doesn't mean you can't treat it, it just means that you're going to be less successful. So if you've got a 5 centimeter tumor, of course you can treat it. You could do some TACE, you could do a microwave, you could do an elaborate RFA that's 5 centimeters, but you know, maybe you're not doing the patient a good service because you're probably going to have to come back and do it again. You probably missed the margin, so maybe you should really let surgeons just take out a lobe. So let's see. And this is reality. And this is the type of patients you really do get. You get the sickest ones, the ones who can't have surgery because they're cirrhotic. You'll get transplant patients just trying to live a little longer to make it on the transplant list or shrink their tumor down a bit. And then solitary, really large HCCs, percutaneous techniques are pretty limited. 5 centimeters, that's getting pretty generous. You know, theoretically you can do it with microwaves, but I'd recommend thinking about something else, especially yttrium these days. That's a different talk. METs. So METs will tend to come your way a lot. And I think you'll have more people asking for metastatic ablations than you'll guess. Unfortunately, many of them have, 5 or 10 lesions. You can't do much about that. Percutaneous techniques, but there are more and more who have, are coming my way anyway, who have, a manageable 3 or 4 METs, maybe colonic, and it's acceptable to treat those, especially if they've already had chemo and maybe they're growing despite chemo. So how about some pictures of some METs? Colonic is a pretty typical one just because it's a prevalent disease. Certainly acceptable to treat METs with percutaneous. Here's an example of one before and after. Here's actually another picture of that same one I showed you, a difficult MET. That one I actually showed you didn't realize, but it was a duodenal MET. It was just one, and it was at the cut surface margin, so IRE. Neuroendocrine tumors, usually they're never solitary, but occasionally you get lucky. And when that happens, you can ablate them, of course. Here was one, if you can imagine a neuroendocrine with a solitary little tumor, it's just like a gift. It doesn't come up that much, but it does occasionally occur. And here's an IRE. Here's the pre, and here's the post. This post is what it looks like 24 hours after. And check out, this is pretty interesting. You can tell enhancement, obviously. Central, no enhancement. This is irreversible cell death. Then check out this really thick, wide zone of enhancement. I think this is equivalent to the penumbra zone, and it looks like this is really going to be viable tissue from the ones that we've looked at. CT doesn't always show this zone. CT shows just kind of a mushy area of nodular enhancement, but MRI is pretty distinct, so that's kind of interesting. Pancreatic adenocarcinoma. So I'm not going to get into it too much, but some of the leaders in IRE who really started it all have done pancreatic, primary pancreatics, as in IRE of the pancreas itself directly. And here we have a liver surgeon we work with who's doing a bunch of those open. And we've had a few that we're doing percutaneous, like through the stomach or through the liver, into the pancreas and IREing the thing, despite the fact there's the portal confluence and the celiac artery, and they have done reasonably well, but it's still a little disturbing. I'm not sure it's mainline at all yet. This is the surgeon here who attempts to do these with us. That's his name. Hepatocellular. This is getting a little too redundant. I think we're going to skip it. So SNH, people are going to ask you for SNH and adenomas to be ablated. You can do it, and there's some reports of other people doing it, so you have a literature base to stand on, but it really never comes up. Here's a new direction. How about cholangiocarcinoma? they are pretty difficult to treat in any way. You know, they're usually never solitary or round. They don't look like something that you'd want to use a percutaneous technique, because they're like a tree. They follow the ducts out. So, but one possibility is using IRE in general. If you have one that's small and it's at the hilus of the liver and it's surrounding the ducts and maybe some important vessels, IRE may be the only thing that you have to offer, if not yttrium. So this is the potential area where you could maybe use IRE because it spares ducts and vessels. I've done a few cases where I'll IRE central tumors that are squeezing down ducts so that the endoscopist can put a tube in if they can't otherwise pass it because it's too strictured. IRE plus or minus other treatments. So there's a lot of research, I think, potential for IRE. If it doesn't go away because of its technical difficulty, there's a lot of interesting areas for the future. There's a summary, and I'm glad you guys listened, and it's a pretty interesting area. If you guys haven't done IRE, I'd look into it. I think there's a definite value for it in the future, mainly doing small tumors next to important things. IRE may be your technique, but if all you had was one device, you would never want to just have IRE. It's too difficult and too limited. You really need something plus IRE, like RFA plus IRE. And that's it. All right. Well, thanks for listening.
Okay, thanks, Dr. Hennemeyer. Sorry I didn't get to introduce you.
No problem.
Computer was malfunctioning, but at this time, we just want to thank you on behalf of the RFS for a great talk. And if there are any questions, we'll take them now.
Yeah, does anybody have questions? I don't hear anybody, and I saw a thing popping up. I think somebody was maybe talking a few times, but I couldn't hear you if you were. But, okay. Don't be scared. Ask anything now. Nope. Okay. Well, I think that's it. All right. Well, I'll see you later.
Okay, thanks. See you later.
Bye.